Okay, so how are you going to make the diagnosis? You have to correlate the clinical signs and symptoms, and there are some investigations which are really going to help you. But most of the time, the diagnosis of acute mesenteric ischemia is clinical. So you have to be very good in picking up your signs and symptoms, so that like a little bit of the investigations. But if the patient is developing acute mesenteric ischemia, and there's generalized peritonitis and tenderness and guarding and rigidity, then obviously it's emergency and you have to take your patient to the OR, and you don't have much of the time to go for a CT or you go for the relevant investigations, and because you have to save the gut. And by the time the patient develops rigidity and peritonitis, the patient has already been long developing the acute mesenteric ischemia. So you don't have much of the time to wait for the investigations. So what are the clinical features? The patient can have severe abdominal pain. So onset of the pain is very, very much important. Okay, so if there's acute onset or sudden onset, you think about embolus. And if there's a sudden or if there's a gradual onset of abdominal pain, then you will think about thrombi, or you will think about a generalized process of thrombosis. Okay, so remember, severe sudden abdominal pain is the key to the acute mesenteric ischemia. So patient will actually say that the pain is out of proportion. He can't actually locate, or he can't actually tell you where he's feeling the pain. So most of the time it's central and it's generalized and it's severe in intensity and it's out of proportion. Okay, so when you ask him to rate his pain, so maybe you would be saying 9 out of 10 or 10 out of 10 on a pain scale. So remember, word severe is important, and sudden is for emboli. And if it's saying gradually developing severe abdominal pain, then you will think about thrombosis, or it can be, the chronic, acute on chronic mesenteric ischemia. He will have a history of atrial fibrillation. He will have a history of atherosclerosis. He might have a persistent vomiting or defecation, or the patient can sometimes give you the history of passage of altered blood in the stool. But usually it's a late presentation. So if you want to pick up this disease earlier, so be more focused on the patron of the pain, because it would be telling you that it's a severe sudden pain out of proportion. So that's the key. Remember that. And the patient will have abdominal tenderness, and the patient can be in shock, but it's a late presentation. Okay. So starting from the clinical features, severe abdominal pain, maybe a history of atherosclerosis, maybe there is a history of valvular diseases, or maybe there is a history of ischemic heart disease or myocardial infarction in the recent past, or the patient has a history of atrial fibrillation. And then the patient might have the persistent vomiting. There can be passage of bloody stools. And when you examine such patient, the patient would be obviously, if he has full-blown peritonitis, or even in a way to develop a peritonitis. So the patient will have tachycardia. His heart rate would be very much raised. And if he has atrial fibrillation along with that, so the patient will have irregular pulse. Remember, the patient will have irregular pulse if the patient has atrial fibrillation along with acute mesenteric ischemia. And then obviously, the patient will have tachypnea, and if the patient has already bled so much, so patient can be in hypotensive hypovolemic shock. So it can either be a cardiogenic shock, it can be hypovolemic or septic shock, okay? So why the patient, most of the time, the patient will have a septic or the patient will have hypovolemic shock because the bowel's perforated and gangrenous, and obviously there would be a lot of the blood oozing from mesentery into the abdominal cavity. So the patient will have tenderness, and that would be generalized tenderness. the patient will have guarding and rigidity, and sometimes rebound can be positive. Okay, so especially you can say bowed like rigidity that can be possible or present in such patients, or the patient can be in shock. So these are the clinical features. Okay, now you have to investigate your patient. If the patient is hemodynamically stable, okay, I'm repeating, if the patient is hemodynamically stable, then what you have to do is that you have the time, you can go for some investigations, and you have to start from the baseline investigation. In baseline investigation, you're sending total blood count, and there would be leukocytosis, maybe possible serum lactate levels are very high. So some baseline investigations include this, but other investigations which are specific, that would be CT scan. But if you have the possibility of CT angiography, so if you're suspecting acute mesenteric ischemia, so you should go for a specific investigation. And the most specific investigation is computed tomographic angiography. Okay, so in the past we used to do the mesenteric arteriography, but nowadays mesenteric arteriography is therapeutic. It's not diagnostic anymore. It's therapeutic when you're planning to do the embolectomy, or you're not embolectomy exactly, when you're planning to do the angioplasty or stenting. Okay, so mesenteric arteriography is specific but related to that. Other than that, when you talk about the other conditions like CT scan is very, very much important, or X-rays can be helpful, but not that much. But in CT scan, there would be thickened edematous bowel, and there would be pneumatosis intestinalis. So what do you mean by pneumatosis intestinalis? That means that there is a gas in the lumen of the gut. Okay, so there's a gas. The gas is not in the lumen of the gut. The gas is either in the intestinal wall, or it's in the superior mesenteric artery or portal vein. So that's called as pneumatosis intestinalis. As you can see here, the bowel wall is very, very thick, and see if you could see the contrast here. So there would be thickness, there would be pneumatosis intestinalis, and these findings can be possible. You can pick it up on X-rays as well, but most of the time X-rays are not very diagnostic. So the most specific thing is you go for the CT scans, or you go for the CT angiography if the patient is hemodynamically stable. If the patient is not hemodynamically stable and patient has diffuse peritonitis, and you don't have a time for undergoing a lot of the investigations, then just resuscitate your patients, resuscitate with the fluids, resuscitate with the antibiotics, resuscitate with the crystalloids and colloids, and then just shift your patient to the OR. So remember, the investigations are CBC, in which leukocytosis and serum lactate levels, they would be high, and other investigation of a time. The most appropriate investigation is CT angiography, but if you are not in a premises where CT angio is instantly possible for you, you can go for X-rays, you can go for CT scan, but it's not possible. The early you can pick up the acute mesenteric ischemia earlier in X-rays or in CT scan. So you need a proper investigation for that, and that's obviously the CT angiography. And mesenteric arteriography is no more. It was gold standard in the past, but nowadays it's more therapeutic. It's not diagnostic at all. So most of the time it's reserved for the conditions in which you have to do the angioplasty with or without the stenting. So CT angiography, whenever someone asks you what is the gold standard for acute mesenteric ischemia, the gold standard is CT angiography. And in angiography you can see exact location of the thrombus occlusion. You can see if it's distal, it's proximal, what part of the gut is likely affected. And there are some investigations which you can do intraoperatively. Okay, it's like you can go for light beam testing, or you can go for fluorescein testing as well. That will actually tell you which segment of the bowel is healthy and which is actually necrosed. Maybe the color of the gut is not very much helping to you, and you're confused and you're not sure about that, and you need some help with the investigations intraoperatively, so they can be fluorescein dye or they can be light beams, which can actually tell you, radioactive light beams that can tell you about the viable gut.